I first wanted to acknowledge and thank all of my co-authors for this work. I'm with Helen Keller International, and I wanted to share with you today, in the next 10 to 15 minutes, some results from a study that we recently conducted, looking at consumption of unhealthy snack food and beverages during the complementary feeding period here in Kathmandu Valley. So a bit of background on why we chose to do this study. In 2013, HKI conducted a survey of foods that were being fed to children during the complementary feeding period in the most populous cities in 4 countries. This included Dakar, Senegal, Dar es Salaam, Tanzania, Phnom Penh, Cambodia, and here in Kathmandu Valley, Nepal. And one of the most striking results from this survey was that commercial snack food and beverage products were very prevalent in terms of feeding. And you can actually see that it was highest here in Kathmandu Valley at over 80% of children 1 to 2 years of age. So when we started sharing these results to stakeholders here in Nepal, regionally, globally, there were a few different responses. The first was, wow, this is quite shocking. But the second was, okay, but how much are they actually consuming? Is it that they're just having one piece of candy in the previous day? Are they having an entire package of biscuits? How much are they consuming? And when you talk about commercial snack food products, do we actually know that they're unhealthy? That's a bit of an assumption. So to answer these questions, in 2017, HKI Nepal went back, and we chose to do a much more in-depth study here in the valley. There were a range of objectives for this study, but I'm going to focus on 2 for this presentation. The first is to describe the consumption of unhealthy snack foods and beverages among children 12 to 23 months of age in Kathmandu Valley, and then to also explore the characteristics of both caregivers and children who are having the highest consumption of these foods. And the real intention of this objective was to inform targeting and interventions that are aiming to improve complementary feeding. So our study population were children 12 to 23 months of age and their primary caregivers. So we defined those as the caregiver who provided the majority of care to a child in the day. For this survey, it ended up being around 90% mothers, 7% grandmothers, and a few fathers, grandfathers, and household helpers as well. Children were excluded if they were severely ill, if they did not reside within Kathmandu Valley, or if they had any physical malformations that resulted in feeding that was not typical. We had an incredible team of interviewers that did wonderful, wonderful work, and so we collected that data through structured interviews using a questionnaire, and then also a dietary assessment. For our sampling design, we used a 2-stage cluster sampling procedure. In the first stage, we assigned 78 clusters across all municipality wards of all 3 districts of the valley based on probability proportional to size. In the second stage, we had another hardworking team of recruiters who went out 2 to 3 days in advance of data collection and went to a randomly selected GPS point within the ward, and through standardized procedures, began knocking on every single door to identify eligible children. They approached over 18,000 households, so this was a huge amount of work, and we ended up having a sample of 745 children. You can see that the distribution of our sample is as would be represented here in the valley in terms of population distribution, with most caregivers and children coming from Kathmandu, then Lalitpur, and finally Bhaktapur. For the dietary assessment, we used an interactive 4-pass 24-hour recall to identify all of the foods and beverages that were consumed by the child in the previous day. This was conducted with the caregivers, and not only beyond looking at just the foods and beverages, we actually quantified the amounts that were consumed using food models and digital scales so that we had an exact quantity of rice in grams that were consumed by the child, how much dal was consumed, and recipes for each and every child in the household. And we use this data to then quantify the energy and nutrient intakes for each child. We used a food composition table that was compiled for this study, and because we were interested in snack food and beverages, many of those were commercial. So after data collection, we had asked caregivers to let us know the brand and the flavor of the products that were fed, and we pulled nutrient content information from those labels. So our outcome of interest is high consumption of unhealthy snack foods and beverages. There are three components to this outcome that we had to define very carefully, so I wanted to walk through each of those with you. The first is, what is a snack? We spent about 3 months trying to figure out what is a snack. There are a range of definitions that are used in research, and we wanted to make sure we used something that was appropriate for the context here in Kathmandu Valley. So we conducted formative research, doing structured observations in homes of caregivers, and also conducted focus group discussions. We asked caregivers, what does the meal pattern usually look like for a child? And what we discovered is that it doesn't follow the typical pattern for adults where you have kana in the morning, kana in the evening, and kaja midday. It's actually that these 1 to 2 year olds are usually fed small feedings throughout the day. So that typical meal pattern wasn't really appropriate. And also because they're fed these small amounts, portion size was also not an appropriate definition, because what they might be fed as a snack could actually be consumed in a larger amount than dal bhat that they received during a meal. And finally, because another objective of this study was to consider the dietary and nutritional outcomes of children who were having high amounts of unhealthy snack foods, we really focused on the types of foods that were being fed as snacks. So to identify these, we asked caregivers, what do you usually feed as snacks to your children? And what we ended up hearing was things you would expect, like cheese balls, instant noodles, biscuits, candy, chocolates, and also things like fruits, milk, lito, and jaulo. So we had one big category of snack foods, and then we wanted to focus in on those that were unhealthy. And to do this, we looked at the nutrient content of each and every food, and we profiled it using a model from the United Kingdom. It's from their Food Standards Agency, and this model has been validated and used in other contexts to identify foods that are unhealthy and should not be marketed to children. This nutrient profiling model looks at total sugar, total fat, and total sodium. So from the snacks, we then focused on those that are unhealthy, and we wanted to know who are the highest consumers and how do we define high consumption. To do this, for each and every child, we looked at their total energy intake. And from this, we looked at what proportion of calories are coming from these unhealthy snack foods. So for one child, it could just be 3% of all of their calories were coming from unhealthy snacks. For another child, it could be 90% was coming from these snacks. So after this was done for each child, we created terciles of consumption. So we had low, moderate, and high consumers. So getting into the results, we identified 239 specific unique snack foods that were being consumed by children 1 to 2 years of age. Of these, 3/4, based on their nutrient profiling, were unhealthy. So the healthy things tended to be things like fruits, milk, lito, jaulo. And those that were unhealthy, 88% of them were commercially branded and packaged foods. The other 12%, it's not that they weren't commercial, it was that they actually weren't branded. So they were things like a donut sold in a bakery that did not come in a package. There were, I don't think, very many at all homemade foods that were actually unhealthy. So this first result really responds to some of the assumptions that we wanted to test. Are snacks unhealthy? And are unhealthy snacks usually commercially packaged? Looking at total energy intake from these unhealthy foods, we found that in the lowest consumers, only 5% of their calories were coming from these unhealthy foods. But for the highest consumers, nearly half of all of their calories were coming from these unhealthy snack foods and beverages. For the total sample, so this is for the 745 kids, on average, it was 24.5%, so a quarter of their calories were coming from unhealthy foods. And what does this actually mean compared to other settings? So these are 1 to 2 year old children, and a rate of 25% of calories coming from unhealthy or junk foods is comparable to what we see among school age and adolescent kids in places like the US and the UK. So we have 1 to 2 year olds in Kathmandu Valley getting a similar contribution to their energy from unhealthy foods as, say, a school age child in Texas. And what foods are driving this? What we found is that it's primarily driven by foods rather than beverages, so that's quite different than what we see in places like the US and the UK. And it's mainly coming from biscuits, but also other sweet things like candy chocolates and bakery items. When we look at median sodium and sugar intake, this fits nicely with that other data. The median sodium intake was 250 milligrams, which is well below the upper limit recommended for this age group. But for sugar, we see that the median intake was 28 grams. WHO recommends that for children, no more than 10% of their calories come from sugar. So looking at the average energy intake for this sample, it should not have been more than 16 grams. That's the upper limit that's recommended. So they're getting almost twice the amount of sugar that they should be getting. And a third of that sugar is coming from these unhealthy snack foods and beverages. So those are primarily added sugars versus natural sugars found in fruits and lactose in milk. And so to answer our other objective, we ran multinomial, multivariable logistic regressions to look at what factors are associated with the highest. So the highest consumers are those who had half of their energy coming from unhealthy snack foods. The first thing that we found was that children of caregivers who are employed in paid work were 1.6 times more likely to be high consumers. So this fits in with some of the hypotheses that we've heard around working moms utilizing packaged and convenient foods for child feeding. Older children were 3 times more likely, which is not surprising given that as a child ages, they tend to move into more and more family foods. They become more mobile, so they can walk around and start grabbing things off of tables. Children from the poorest families were, in our wealth quintile, was the poorest family group was 3 times more likely. Children of caregivers with lower levels of education were 2.3 times more likely. And children who are not from upper castes were between 3.6 and 4.7 times more likely. So what this indicates to us is that those groups that are in most disadvantaged are the ones that are having the highest consumption of unhealthy snack foods and beverages. And these lower socioeconomic status families are the ones that are already typically vulnerable to nutrition and food insecurity. We saw this morning that we're seeing increasing rates of use and purchasing of ultra-processed foods, and I think it's something that we're increasingly seeing as the food system is changing. When we look specifically at diets, and in this study what we can see is that within those households, it's probably being used in different ways. And so what we know from here is that at least in Kathmandu Valley, in this urban setting, it's making up a large proportion of diets for young children. And given that many of these foods are unhealthy and that young children's nutrient requirements are quite high during the complementary feeding period, there's also a need to really investigate what is the dietary and nutritional impact of this consumption of these unhealthy foods. And this is something that hopefully HKI can answer with additional analysis from this data set. So thank you.